Hello again, welcome to our video series looking at pediatric EKGs. I'm John Felt, and I'd like to welcome again Dr. Sriram, who has been helping us out. We have another fascinating case today, so we'll go ahead and jump right into it. This is a 7-week-old female that presented to our emergency department with a chief complaint of nasal congestion and some difficulty in breathing. She'd also had some fever. She was noted in triage to be tachycardic, but it was felt that this was due to her crying. She also had some mild tachypnea and a fever of 101. Initially, the workup consisted of bringing her fever down, so she was given some antipyretics. On reassessment, she remained tachycardic despite being afebrile. Because of this, then the team initiated a workup. They decided to do some fluid resuscitation to see if that would improve her tachycardia. It did not, and so then EKG was ordered, and that leads us to the case. Here's the EKG.
Thank you. When talking about narrow complex tachycardias in children, you obviously start by looking at the QRS to make sure it's really narrow, because sometimes you can have what you think is a narrow QRS in one lead might look different, or a wider QRS in a different lead. So if you are sure that it's a narrow QRS, and if you don't, and obviously you can compare that with your sinus rhythm baseline, but if you don't have it, then you look at the duration of the QRS in different leads, and if you're convinced it's a narrow QRS tachycardia, and if it looks like compatible with what a sinus conducted beat would do to the ventricle in terms of its axis, then you can proceed further. That's the first step. Obviously, when you have a narrow QRS tachycardia, you look at the heart rate. Sinus tachycardia is always in the differential, especially in this patient who was an infant and has got a heart rate of about 200, and I think it's a 6 or 7 week old baby. So that's not incompatible with sinus tachycardia. So really the key things that you're looking for are beat to beat variability, and if there's any increase or decrease in the heart rate, which suggests that there's a physiological variation. Obviously a heart rate that's consistently fast in the setting of a baby or a child who is calm, that points more towards an SVT. But on the other hand, if you have a crying or a screaming child, that heart rate may be elevated, or if you have a fever, that heart rate may be elevated. So when you're dealing with narrow QRS tachycardia, really the diagnosis hinges upon finding P waves. And when I say finding P waves, you not only look for P waves in different leads, you look for that P wave relationship to the QRS, and you look for the ratio of the P waves to the QRS. If you have 1:1 narrow complex SVT, that in and of itself gives you a diagnosis of either AVNRT or orthodromic ORT, sometimes atrial tachycardia with 1:1 conduction. Obviously, if you have more P waves than QRSs, either 2:1 pattern or more P waves in general than QRS, then it points to a diagnosis of an atrial tachycardia. And I think it's a good idea to just spend some time staring at the ECG and trying to look at all the leads and try to see if you can see any P waves and to see if you can march them out. Just eyeballing this, if you looked at lead 2 and if you didn't pay too much attention, you could say, well, I see these guys here that are probably P waves, and you would be right. And then you would say, well, it's positive in lead 2, and I don't see it clearly in other leads. So maybe I see this in lead V3 here again. And you may convince yourself there is 1:1 conduction between the atrium and the ventricle, and given a heart rate of 200 and a P wave axis that looks positive in lead 2 and is positive in the precordial leads, such as lead V3 here, you may convince yourself that there is a 1:1 tachycardia going on, and there is a 1:1 relationship between the atrium and the ventricle, and you may start thinking maybe this is just a sinus tachycardia. I think that's probably what happened with respect to this patient. The heart rate was not too high, child was screaming. Obviously, people thought maybe this is just a 1:1 sinus tachycardia. And again, most oftentimes you would be right, but obviously when you have an ECG, it's nice to kind of look at all the leads to see if you can see more than one P waves. And I have to say honestly that if I look at lead, and you have to look at multiple leads, but I think if you look at lead 1 in this scenario, in this case, I can just blow this up a little bit to kind of define this better, you start seeing something, and you start seeing these ditzels here. And obviously you have to take your caliper and march them out to make sure that you're not imagining things. And if it nicely marches out, and if the A to A rate is half the V to V rate, or if the atrium to atrium rate is the same as the ventricular rate, then you have to assume that this is an atrial tachycardia going on with 2-to-1 ventricular conduction. Obviously, sometimes you can get fooled by bumps on the T wave that you might assume as P waves. And that's why you have to look at multiple leads and march them out. And again, in this scenario, don't be shy to get a long rhythm strip. If you think P waves are best seen in lead 1, of course include that in the rhythm strip. But getting a 12-lead rhythm strip, a long one, actually helps you out in this scenario. And then, again, don't be hesitant to give adenosine, because it can block the AV node and unmask the P waves. So those are the two things that you will do. If it's sinus tachycardia, obviously you can slow down the sinus rate, you can block the AV node, and you won't unmask more P waves than QRS, but you would probably not be doing a lot of harm. Again, adenosine can cause asthma, worsen asthma, and a patient who's predisposed to it, obviously you take that history into account. But in somebody like a baby, I think the effects are going to be transient. Any bronchospasm that you might have is transient. So you should be okay giving adenosine as a rapid push and unmasking the P waves. And once you can see that, then the diagnosis becomes obviously clearer. Sometimes just getting that long rhythm strip might let you see more clearly the P waves and kind of march them out. So I think that's the real key here. And then obviously once you have sinus rhythm, either because you cardioverted the patient or the patient converted spontaneously to sinus rhythm, then you look at the P waves and sinus rhythm, look for pre-excitation and other things. Compare that QRS morphology during sinus rhythm to the SVT. If it's really a narrow complex SVT without bundle branch block, they should look pretty similar during SVT and sinus rhythm, the QRS morphology. Again, the key here is to look at all the leads carefully, consider the possibility of 2:1 conduction, consider the possibility that there might be a flutter hiding. Again, you may be wrong, but again, there's no marks for being wrong. You don't get any negative marks for being wrong, but you do get positive marks for being right. If you uncovered a flutter, then that's obviously something that is, you did good for the patient. You prevented the patient from being in flutter for a longer time. You can treat the patient, shorten the length of the hospital stay. All right.
All right, so thank you, Dr. Sriram. This was a great case. So in summary, what we have here is a young infant who ended up having a tachycardia-induced cardiomyopathy. Her presenting arrhythmia was a atrial flutter with a 2:1 conduction. So the EKG showed a ventricular rate of 198 beats per minute, and her atrial rate was somewhere in the neighborhood of 400. So certainly something that needed to be dealt with. Some interesting points about this case that I think are good take-home messages for the ED physician, especially those that are not used to dealing with children. Number one, the importance of not dismissing persistent tachycardia when the most common things have been addressed, such as fever, as well as dehydration. As well as making sure that vital signs are tried or attempted to be captured when a patient is calm, especially a young patient, so that there's no excuse that the vitals being abnormal is possibly due to the patient's crying, as was the case in this particular patient. Additionally, for those that aren't used to working with children, it's important to recognize that even though atrial dysrhythmias are fairly uncommon in young children, they still do exist, and especially in the case of tachycardia-induced cardiomyopathy, when the rhythm is addressed and rate control is achieved, there is dramatic improvement in the patient's cardiac output. And in this patient's case, she was off medications within a few weeks with full return of heart function as soon as rate control had been achieved. Additionally, the use of adenosine as a diagnostic and therapeutic medication is an important principle to consider, as this can be very helpful when an EKG is very difficult to read due to the fast heart rate, which we often see in young children, and therefore the use of adenosine to help slow the heart rate down so that you can see where the P waves fall is a very important diagnostic tool, in addition to also being the treatment most times for these atrial dysrhythmias. So we do thank you again for joining us today, and we will see you again for another interesting case.